reverse cart, when and how. See, once you went retrograde, your retrograde microcatheter is here and your wire is here. So what are the options available for us? So one is just send your wire true to true, right? I mean, that's not in your hand. It can be true, false, to true also. That is, yeah, possible intimal tracking is one option. And or use your antigrade wire, and by using retrograde wire as a marker, you can send your antigrade wire. That's a marker wire technique, so which we have demonstrated yesterday. Or third thing is, you can go ahead with reverse cart within the lesion. Okay, so see, majority of retrograde procedures end up in reverse cart. That's how we go with the plan. As I explained you yesterday, when you go retrograde, you should have a plan what next you want to do. So, I mean, this is my data. You can see this is Japanese CTO registry. Nearly 64% of the cases you end up in reverse cart, and we have done reverse cart in almost. I mean, my data it is nearly 47-50%. It must have increased. This is somewhere done in 2021 or 22, so it must have increased now. So there are various types of reverse cart. When if you open literature, case reports, it's when there are plethora of descriptions available. That's what confuses people. Conventional reverse cart, extended reverse cart, Iwas-Gear reverse cart, guideliner, stunt assisted. Ever since this paper, published, which unified, all the thought process of reverse cart into uh, one kind of methodology. So now we have only these three reverse cards. That is directed reverse cart, conventional reverse cart, and extended reverse cart. See, coming to directed reverse cart. So for directed reverse cart, I mean, first you have to choose the site for reverse cart. Any reverse cart, you have to choose the site for reverse cart. So in directed reverse cart, the site is within the lesion itself, right? And you choose a straight segment of the vessel within the lesion, right? And use a zone where there is no calcium because connection becomes very easy. And use a zone, which is not knuckled as well, because knuckle creates a huge space and your connection becomes more and more difficult when you created a space. If you look at this case, the ideal position, where you can do reverse cart is either do within this straight segment, okay, or you can do in the straight segment of, this zone of RCA, not at the bend, okay. So in directed reverse cart, what we do, right? You go antigrade fast, like this, and that's antigrade preparation fast. And take a balloon, so smallest balloon, not like 3 or 3.5. Take 1.5 or 2 millimeter balloon, because small balloon you are creating a small space. Lesser the space, better the possibility of connecting fast, right? And then you take a retrograde wire, which is a directable wire like Gaia 2 or Gaia 3, right? And direct your retrograde wire onto the balloon, either side of the balloon or end of the balloon, in two orthogonal views. Okay. So all this is done within the lesion. So that is directed reverse cart. And this is the default strategy of most of the C2I interventionists now. The reason is you are creating less space and you are going to be successful in short time. As I already mentioned, time is the key. Whatever you do in C2I interventions, the time is the key. You have to achieve everything in shortest time as possible. You can see now, see, this is a graphic representation. You went retrograde, your microcatheter is there. You have antegrade preparation already done. You took a balloon that's 1.5 or 2 mm. Then you take a retrograde directable wire that is Gaia 2, right, and direct it to towards the end of the balloon, the space toward the end of the balloon, and deflate the balloon, and you push it. Okay, you will reach antegrade space. Sometimes you can even go from the side of the balloon, right? So in this process, you are creating less space and success on time. So you can see this is a case. What happened? Yeah. So this is a case where we did direct reverse card. So this is antegrade wiring. You can see wire is somewhere. It's not in the vessel. I think subintimal and went somewhere. And there is a balloon on the wire, right? And we went retrograde, right? Corsair is gone retrograde, and the retrograde wire is Gaia. This this is Gaia 2. We took a directable wire. Now you can see antigrade balloon is inflated. I think it's probably 2 millimeters balloon, and retrograde Gaia 2 is aimed towards balloon tip in two views. This is LAO, this is RAO, right? And deflate the balloon and push it. Okay. So, and you externalize subsequently. So, and you finish your procedure. So, this is director rewards card. So, why it should be default strategy is it avoids creating too many wire tracks, right? And creating too much of space with your bigger balloons. And it increases success of connection in shorter time and very minimal injury to the vessel. So that's why this is the default strategy in many retrograde interventions. And conventional reverse cart. This, in most of the interventionist practice, in fact, even in my practice, when director reverse cart failed, then we'll move on to conventional reverse cart. So what is this conventional reverse cart? So here what we do in conventional reverse cart, so you go antegrade, I mean, you can do antegrade preparation, right? You are going retrograde, and your antegrade, what we do is we take a bigger size balloon, something equivalent to the vessel size, which can be decided based on IOS. It could be 3 or 3.5 mm. Just go with the balloon which is equivalent to the size of the vessel, and then take retrograde. It could be directable wire. So, and get into this space, right? So generally this we do when as a graphic represents, if you have loops within the CTO segment, it is very difficult to, execute directed reverse cart. Okay. So often we end up in conventional reverse cart because your antigrade wire will be in one side in the CTO and retrograde wire will be on the other side. Okay. So that's when you end up in doing a conventional reverse cart, and mostly in a loopy vessel when CTO segment is loopy or you're doing reverse cart in a loopy area. And often once your directed reverse cart is failed, then we end up in conventional reverse cart. So you can see this is a case where it's a very calcified, post CABG CTO. We went antegrade, I think, with Gaia 2 and Miracle. And then when retrograde, you can see this is a retrograde microcatheter, which is coming from epicardial collateral. And initially, I tried direct reverse cart within the lesion. Okay. Because it is calcified CTO, I was not able to connect. Okay. It's very difficult to connect in a calcified segment. Okay. And whole CTO is almost a calcified segment here. So I was not able to connect. In fact, I upgraded my retrograde wire to Harnett. Okay, not Gaia 2. Okay, from Gaia 2 to Harnett because it is calcified. Uh, but still, it was not successful. So then we moved on to conventional reverse cart. This is conventional reverse cart. I took a 3.5 balloon, right? You can see now. And we directed retrograde, again, directable wire, right? And tried, reverse cart successfully, and then we completed procedure. You can see the lot of calcium around the stent segment, which made this uh, direct reverse cart more difficult. Extended reverse cart. So this is basically, where you do your reverse cart in the normal segment, not within the CTO segment. You can see here, see this vessel, um, it's an ambiguous cap, right? So what we did, we just went through the ipsilateral septal palatal without IVS guided cap puncture. We couldn't do IVS guided cap puncture because of the angulation and calcified proximal cap. So we went retrograde. You can see ping pong guide, and this is the retrograde wire. And I'm keeping my balloon inside the normal segment. Okay. So when you're doing a reverse cart in normal segment, okay, either proximal or distal to the CTO, right? Often we do proximal to CTO. Often it is because of the ambiguous cap, right? So you're doing reverse cut within the normal segment and you're directing balloon towards, sorry, wire, retrograde wire towards the balloon. I think you understood by now. You can lose this side branch, okay? But what we do always is your retrograde wire, you keep it as close as possible to the carena, okay? So, I mean, in when the septal is like this, your wire should come close to septal ostium and enter, okay? Not from away, okay? So if it is away, I told you, you will shift entire block onto septal. But in this particular case, because this septal is filling from this septal, even if you occlude, later this septal will receive from blood from this because you're opening CTO. Okay. Subsequently, distal septal can fill proximal septal. So it's fine. So nothing will happen. So, I mean, that is what we did. And, we went ahead and centered. You can see as we are close to carena, we didn't lose septal flow. But even if you lose, your distal septal will fill the proximal septal. Nothing to worry about it. You're not going to cut off flow to septal. So this is extended reverse cart. And you see this case, what reverse cart here? Can you do extended reverse cart here? I already told you, ambiguous LED CTO is the most deadly, CTO intervention. So there is no question of doing extended reverse cart. So if you put a balloon in LMCA and bring your retrograde wire into LMCA, and if that is subintimal, then you are going to occlude LCX. Okay, patient can have an on-table cardiac arrest. So no extended reverse cart in this kind of scenario. Understand? So it should be antegrade cap puncture first. This is this is what can happen. So if you do an extended reverse cart, okay, so it's completely barred. So the ideal is just do antegrade cap puncture. I was guided, and then go. I mean, if your wire reaches distal true it's fine, right? You can finish your antegrade. If it is not reaching distal true lumen, and if your antegrade wire, sorry, I mean this is without IVUS. If you do, what can happen? And you do with the IVUS guide cap puncture, then go retrograde, okay, and do reverse cart beyond the ostium of LID. Okay. So here I told you all the rules, the wire shouldn't come to the ostium. That's a main rule, which we have to follow. And this is a clear graphic, which explains, uh, as already mentioned before. So this is the balloon. After I was graded cap puncture and retrograde wire is in place, and you take this space, you keep pristine, don't come into this space with retrograde wire. So your retrograde wire should enter into true lumen beyond that space, right? If you don't want any inflow injuries. Okay. So, and I showed you already, how inflow injury can affect. You can see here, this is LMCA, it's all subintimal hematoma. And you end up in stunting, complete LM to LCX. You can see here, we did uh, we did end up in stunting both LMC and LCX. So there can be many difficulties in reverse cart, like finding a collateral channel, crossing a collateral channel, and navigating up to distal cap, and wide crossing of proximal or distal cap or CTO, and connecting spaces, and navigating proximal to CTO vessel, and externalization of wire. So when you can have multiple difficulties, you see, if you have a PDA like this, it is quite coaxial with PLVB. It's very difficult to direct your wire into the proximal RCA. It's almost impossible. Now we have an option of using a W-lumen catheter Sasuke, which can be used even retrograde. But before that was not there. But even then, it is quite difficult to go back. So uh, here, it's very difficult to even do a reverse cart as well, because the wire can't be brought into distal RCA. Often you use your retrograde gear as marker and you send your antigrade gear. Okay, so and this is uh, another case. You can see again how your PDA is opening. It's more coaxial with PLVB. So we tried antigrade, it was subintima, so we went retrograde, but we were not able to direct wire towards distal RCA, and we used retrograde gear only as a marker and an injection so that I can guide my antigrade wire more specifically. So that's what we did. We used retrograde wire as a marker and advanced and closed it. And you can't achieve a reverse card there. You can also see this case. Again, your PLVB is, sorry, PDA is more coaxial with PLVB than this large CA. We went in, but you can see wire just went into PLVB. It's very tough to navigate that wire into this large CA. And now I used this wire as a marker just to do a, ADR. So, I'm just taking a knuckle uh, from antigrade, right? And once the knuckle is coaxial with this vessel, from there, we went with the uh, ADR with the cross boss. I took a cross boss and advanced cross boss uh, where the knuckle is coaxial with the distal vessel. So we use cross boss in a straight segments. Okay, and when the vessel course is not known, never use cross boss. Okay, and fortunately it went from two to true, so we finished stunting from RCA, proximal RCA to distal RCA, and you can see the vessel is flowing, and you can also see my distal gear is still there, because when you do ADR, you have to make sure your PDA is not lost in your ADR. So if it is lost, then again you can do a puncture from retrograde wire, and you can rescue PDA. And navigating within the lesion sometimes is quite difficult. So you can see here, so your antigrade wire is somewhere and retrograde wire is somewhere. You can see in both the LAO and RAO views. So it's a wire divergence. You're not able to decipher. And we tried redirecting wires, and again, this was another position where again there is a wire divergence. When there is wire divergence, what you can do, take a retrograde knuckle. So I prefer retrograde knuckle, not antigrade, because if you do antigrade, it is directly connected to the aortic pressure. You will keep on expanding subintimal space. Retrograde, it is not connected to aorta pressure. The pressure inside the distal vessel is very low, so you won't end up in expanding subintimal hematoma. So we did a retrograde knuckle. You can see, yeah, yeah, this is a retrograde knuckle. See, that's the only way, we can uh, find a solution to wire divergence. Okay, and yeah, you can see now wires are overlapping, but you have to stop your knuckle beyond your proximal cap. So never come close to proximal cap, because you end up in creating a huge space. Then your re-entry also becomes quite difficult. So we stopped beyond the proximal cap, and from there again we took a directable wire and did an extended reverse cart. Okay, extended reverse cart and finished. And sometimes it is quite difficult to externalize also after achieving a successful reverse cart. You can see here, we tried antigrade. It's a very short CTO. Tried antigrade, but went subintimal, then went retrograde, right? And then did a reverse cart. Again, extended reverse cart after failed directed reverse cart. And we felt the wire is in the true lumen, but we were not able to externalize. We were not able to bring the wire into the guide. That's when we did an IVUS. You can see this is a wire in the distalmost part, somewhere here. It is subintima, right? And then it comes into true lumen. You keep watching. Now it is in the lumen wire, and further proximally, somewhere here, you keep watching. The wire again goes, subintima. You can see here. This is what happened. So further proximally, see when you have loops in the proximal vessel, and you're navigate, yeah, you see this wire, it went subintima again, and it is not coming into guide. Okay, when you have loops in the proximal vessel, these wires can go again back into subintima. That's when, what you can do, you send a guide extension till the point where it is in the true lumen, that is point B, right? And then, yeah, that's what we did. That's a guide extension at the point B. And now you can see the wire just went into guide extension. Okay. And that's what you can see, and you can finish. So yeah, this is another RC occlusion wherein, so antegrade wire created a huge subintimal space. I told you, this is how you shouldn't use, filter XTR. It created a huge space, so I had to go retrograde, and then uh, did a reverse cart. But unfortunately, we were not able to externalize, despite guide extension. Then we did an IVUS. You can see here. So my antegrade gear is in the subintima. This is a retrograde. This is retrograde wire. Retrograde wire is actually in true lumen. Antegrade wire is subintima. So now your retrograde wire has to, if you want to come to subintima, you have to penetrate across the uh, flap, or you can just do a IVUS guided retrograde wiring. You just send the wire and keep watching in IVUS, and take it back in true lumen, right? So that's another thing which can be done. So we just did IVUS guided retrograde wiring, and pull the wire. You can see here. Here again, this is subintima. This is true lumen. Next, subintima true lumen. Almost here, this is where actually dissection started. You can see both the lumens are nearly joining. And next, now you can see there is only one lumen here, and both wires are in the true lumen. So you can see both wires are true lumen at the close to the ostium of RCA. So yeah, you externalize that wire, and you stunt, and you won't lose any branch. So that's most important. So yeah, in a difficult reverse card, what you can do, overlap two antegrade and retrograde wires, and then do an IVUS. Okay, so after creating a space with 1.5 mm balloon, and see where two wires are in one zone. That is, both wires in intima, both wires in subintima. It is easy to connect. If one wire is in intima, other wire is in subintima, it is difficult to connect. Okay, and the most difficult thing is when antigrade is subintima, retrograde is intimal. Okay, that's the most difficult to connect. So you can see these are the various wire positions. So both intimal, both subintimal, right? And this is what you can do. You can just do a conventional reverse cut with a bigger size balloon possible and take a retrograde wire. You don't need a directable wire when both wires are in the same space. You just take either Scion or filter FC, right? And take a biggest balloon possible and create space and send this wire, which goes in that space. So, or you can use even guideline or assisted reverse card. And stunt assisted, we are not using. I mean, it's not in practice as of now. I think I should say it's very rarely used. Okay. And when your antigrade is subintimal, retrograde is introlumen. This is what the case I showed you. You can move base of operations, or you can just do I was guided retrograde wiring as I already showed. And when your antigrade is in intima, retrograde is in subintima. So again, take a biggest balloon size possible with IVAS, and your retrograde wire should be. See, you have to go across this flap. It should be as stiff as possible. Either take conquest or harnett and penetrate through it, or you can also use I was guided wiring again, retrograde wiring. So, uh, or you can just do a retrograde knuckle for subintimal entry as well. Okay. So this is our, 5-year data, the dispersion of all these different reverse cards in my practice. To conclude, reverse card is a predominant method of connecting antigrade and retrograde spaces. Directed reverse cart increases success of connection by minimizing space created. And choose optimal site of reverse cart, straight segment, minimal calcium or no calcium. And in case of difficulty, first resolve the ambiguity, bring both wires, subintimally, and you can use IVAS if needed, or knuckle wire if required. And you can use guide extension, and you can move to a new favorable spot, increase retrograde wire reach. That is basically using a stiffer wire with bigger bends. Create a target with scaffold, that is stunt assisted reverse card. And you can also switch to ADR or tip detection ADR or facilitated ADR. I mean, whichever is feasible in that case. Thank you.